Is it right hip, left hip? Both? Both, okay. So if you bend up both knees for me, because sometimes people will, and I'll even test this as well, we can use a supine hip flexion assessment as an assessment of a posterior pelvic tilt as well. Because in order to get that knee to the chest, the pelvis has to be able to posterior tilt, right? If I bring that knee to the chest and I try and keep the femur in the sagittal plane, any pain, any restrictions, limitation, pain in the front? No?
I just feel a little contact here.
A little pressure in the front there, okay. But I can get that knee to his chest. Now, and the femur stays in the sagittal plane. Now, naturally in clinic, you're kind of going through this quickly with the client just to see if they have that availability. But in that scenario, the femur will go through a certain range, and then the pelvis will kick in to actually allow the femur to go further. So it's a nice reflection of, okay, can the pelvis actually posteriorly rotate? Because sometimes that can be hard to say, okay, is the pelvis able to actually posteriorly rotate? Getting the knee to the chest is a nice reflection of that. If, for example, we wanted to only constrain the focus on the femur, then we'd actually need to try and limit that posterior pelvic rotation, right? Now, we can do that with the knees bent here as well. I'll generally have the clients put their hands under the lumbar spine, just to keep the lumbar spine a little bit more extended. And then I'll go through the motion there again. So as I come through here, that's kind of when we hit that little bit of a block there. You feel that there? Now I can go further, but then you'll really see, you'll kind of more clearly see the pelvis go further forward there, right? So for me, again, this is where you have to know your range of motion measurements too. Like, what's the normal range of motion of the hip? It's 120 degrees, right? So if I get to here and all of a sudden that pelvis starts to tip backwards at 90 degrees, then I'm thinking he just doesn't have that availability there. So I may need to expand that. But if you can get beyond 90 degrees without that pelvis tipping back the way, then for me, he has that availability in the hip to do the job. Does that make sense? And so I'm just seeing what's available there. But when you do it actively, that's when you feel like your pelvis tips back. Like if you try that there.
I feel like I cannot move it.
Yeah,
forward,
yeah.
Only if I move pelvis.
Yeah.
But when I'm doing leg presses, squats, I can go down.
Yeah.
But basically just the eccentric portion that I can control more.
Now, the thing is, that's quite normal to do. Like, if you come up to standing for me for a second, if everybody comes up to standing for just a second, and if you were to try and just bring your knee to your chest, again, you're challenging your balance here. If you try and bring your knee up as high as you can, just to see how far you can get it up, just kind of get an idea of how that feels. Now, if you try and get a little bit more extension in your spine, a little bit of a tilt forward of your pelvis, and try and bring it up then, you're going to feel like you don't have as much range of motion, right? That's normal because now the pelvis is rotating over top the femur, which is going to block that motion a bit more. In order to get further, you'd have to posteriorly tilt your pelvis in order to get further through that range. Does that make sense? So I think as long as you have the hip flexion availability, there's not an intention there to improve range of motion, but we may need to perhaps get more load into the hip extensors at length, for example, right? So if we quickly, we may have to get more local load into the hip extensors at length, okay? Maybe to just build muscular tolerance there. If he feels like when you're doing like a loaded task, for example, hip extensors have to lengthen. If you feel like you quickly tip back, it could be a case where if they're avoiding length and load, then we need to be more focused on getting that length and load there. Does that make sense? Let's just see how the hips feel with that kind of quadruped variation. Now, I'm just showing you this, you guys can sit down, but I'm just seeing how it feels here. So let's say we're going to do the right hip. So if you kick the left leg behind you, keep that there, rotate this leg in externally. And if I have you sit back a little bit, so you'd have to slide that left leg back a touch, separate your hands, so kind of widen out the stance of your hands, and then shift your pelvis to the side, and then just gently crush your right knee down into the, do you feel that kind of kicking in there? Yeah. It's a nice kind of concentrated load, right? Now, sometimes, and again, this is just other assessments, in clients that have really limited hip range motion, you may, and some of you might notice this here as well in yourselves, as you shift the pelvis to the side, it may be very blocked, where they actually can't get that femur to, it's essentially like an adduction of the femur. They can't actually shift, they're blocked there. And they just shift and then everything turns away, okay? So that may be a case where it's more like a frontal plane limitation as opposed to a kind of a sagittal plane limitation as well. But this is why stay within the sagittal plane first and then branch into the frontal plane, transverse planes later. Because if you start thinking transverse plane, frontal plane, it's just too much to think about what could be limited there. Stay sagittal plane first and kind of relate everything back to the sagittal plane, okay? But you can get that length and crush down. If you were to rotate into it here, you might get a little bit more length and load there as you crush down. And you can manipulate the intensity. So I can have you really build that crush into the knee there. Do you feel like kind of intensifying the sensation there? Yeah. And so it's just a nice way to expose that area to load. Okay. Now, if, for example, let's say he was someone that didn't have the range of motion, when we're trying to approach that, then it may be a case where we may have to start up a little bit higher, and we may have to kind of just be more mindful as to how much that femur is going through, because if he shifts back and then all of a sudden we see that pelvis go the opposite, where it rounds, then that's not what we want. We want to try and keep the spine nice and straight. And let's say here he starts to tip back, then we just stay there, build some low intensity load through the knee, and then we try and gradually shift back further and further. So we're just doing lower intensity loading and then gradually nudging the restricted barrier, as opposed to just getting him into a position and then crushing to build tolerance. It would be a different kind of process to expand that range then. Did you have a question?
I mean, why we choose that? We suppose that he has a limited hip flexion, that's why we choose that?
It's an option if we wanted to. If you want to improve range of motion, for example, what do you want to happen at the muscles? You want certain muscles to lengthen and certain muscles to shorten, right? So if I'm trying to improve hip flexion range of motion, I want the hip extensors to be able to lengthen. So I need to find the position to lengthen the hip extensors, but also I want to get some load into them at the same time.
That's why we choose that.
That's why I always...
Apart from the frontal plane,
It just gets more length into the hip extensors. That's it. Yeah. We can stay in the sagittal plane where we just kind of move straight back. But if I want to expose the glutes to more length and load, then I can choose something like that then as well. Okay. Sorry, how do you feel? You feel like the glutes are burning? I just had you sitting there. Feel okay? Good. So that's important from a range of motion standpoint. If you're trying to expand range of motion, you could think about, okay, I could get load into the hip flexors in a shortened position as well. But that's where you have to consider, well, when you have a muscle in a short length and you get load into that muscle when it's in a short length, the tension is very low, meaning it's not really building the tolerance. But you can probably sense a lot of load there. So for example, if everybody puts their hand out in front of them now, and if you try and make a grip your fist as hard as you can, when you look at the angle between your metacarpals and your forearm, do you see a little bit of an extension angle? There's a slight extension. When you grip really hard, you'll see a slight extension angle, right? But now, if you were to flex your wrist as much as you can, try and really squeeze. Now, it's not as easy, right? But do you feel more load coming through the forearms, right? So you feel more load, but it's not that you're generating more force. You feel more sensation there, but it's not secondary to more load and force going into that tissue. So that's why we can't let ourselves be confused about what the client senses. We have to understand the length of the muscle that we're loading. Okay? So if I'm trying to get more load into a muscle, it needs to be closer to more of a lengthened position or its mid-range, so I'm actually getting higher load into that muscle. Okay?